Welcome and thank you for joining us. We are very grateful to have you joining us this evening for In the Know 2025. My name is Melissa Weaver. I am a licensed clinical social worker. I am the member service manager and a therapist at Here for the Girls and H4TG Counseling. Our discussion regarding the latest in cancer care and research will offer each in the know expert the opportunity to share their insights, followed by a question and answer period. Speaking of question and answer period, it seems as though there might be a little bit of a technical difficulty with the chat feature for participants. So please use the question and answer feature. To help us dive right into the discussion, we will post introductions, larger introductions and bios for each speaker, which you should have actually already received in an email earlier, and ways to learn more. Discussions will be conducted in an open format where questions are encouraged and connection is crucial. Before we introduce tonight's panelists, we would like to share that In the Know is a live expansion of H4TG's annual health guide, a guide to caring for yourself that is published in conjunction with our annual calendar, which recognizes and shares the journeys of many young women diagnosed with breast cancer. The information presented is for educational purposes only, and for answers to specific healthcare questions and concerns, you should consult your healthcare provider. We did want to let you know that this video is being recorded and will be used to provide additional educational information within community settings with our medical partners and with our members. So now we get to the exciting part of welcoming our participating panelists and healthcare systems. We are so grateful for your time and for your continued dedication to not only tonight's event, but to the amazing life-saving work that you perform every day. Full biographies can be found within the participant chat feature or would have been sent out in your reminder email. I will be introducing each speaker, and then we will move into the question and answer discussion that we're going to have with the speakers. And then we'll conclude the evening with the question and answer period with our participants. We will stop our question and answers about 5 minutes before our webinar ends to make sure that we get as many questions as we can in. However, if we don't get to every question, we will be sending those to the physicians if they would like to follow up. Also, some of our physicians might answer those questions directly if that feature is allowed. So I have the pleasure of introducing Dr. Javinsky. Dr. Javinsky is a surgical oncologist and director of the Oncology Service Line for Riverside Cancer Care Network. Dr. Javinsky specializes in complex and recurrent cancers with an expertise in breast, skin, pancreatic, liver, and gastrointestinal malignancies. Dr. Javinsky is board certified in surgery and surgical critical care, fellowship trained in surgical oncology from Ohio State University, and a fellow of the American College of Surgeons. Welcome, Dr. Javinsky. Dr. Balancha Javasi is a hematologist oncologist with clinical interest in breast cancer and classical hematology. She completed her training at Yale New Haven Medical Center and Henry Ford Cancer Institute, where she was named Fellow of the Year. She is a dedicated educator and leader and previously served as the Chief of Medicine at Grandstand Medical Center and has received multiple teaching and research awards. She is active in national organizations, including ASH, ASCO, and the ACP. Dr. Danzo, who provided content for this evening and for our health guide, is a board-certified medical oncologist with training from the University of London and Memorial Sloan Kettering Cancer Center, where he served as chief fellow. He specializes in breast and gastrointestinal cancers and has served as a principal investigator for numerous national clinical trials. Dr. Danzo is an active member of multiple national medical societies and co-editor of Hematology and Oncology Pearls. Shurtika Yola is a genetic counselor with over a decade of experience in oncology genetics. She serves as a medical science liaison at Myriad Genetics and previously worked in clinical leadership roles at Northside Hospital and Rocky Mountain Cancer Centers. Passionate about equitable care and education, Shurtika is active in the National Society of Genetic Counselors, where she has served on the education committee. Dr. Mount Zairis is a board-certified plastic and reconstructive surgeon and faculty member at VCU Massey Comprehensive Cancer Center. She specializes in complex reconstruction, aesthetic procedures, and microsurgery. She is known for her patient-centered approach, surgical innovation, and commitment to training the next generation of surgeons. Dr. McGuire is a professor of surgery and chief of breast surgical oncology at VCU Massey Comprehensive Cancer Center. She specializes in breast cancer care and research focused on minimizing intervention and improving outcomes. A graduate of Eastern Virginia Medical School, Dr. McGuire trained at Thomas Jefferson University and completed a breast surgical oncology fellowship at Moffitt Cancer Center. She is a respected educator and leader in national surgical organizations. Dr. Jablonka is a board-certified plastic surgeon in Virginia Beach, specializing in breast reconstruction after mastectomy. He completed his training at Mount Sinai, followed by fellowships in microvascular surgery at the University of Pennsylvania and craniofacial surgery at Stanford. Dr. Jablonka's practice emphasizes collaboration, education, and personalized care to achieve optimal reconstructive outcomes. Dr. Wilson is a board-certified surgical oncologist with Sentara Medical Group in Hampton Roads. He specializes in breast cancer and complex oncologic surgery. He completed his fellowship at Roswell Park Comprehensive Cancer Center and is dedicated to multidisciplinary patient-centered care. Dr. Wilson also leads initiatives in program development, quality improvement, and mentoring within the Sentara Oncology Network. A very, very warm welcome to all of our panelists. Our experts will discuss vital, clinically relevant breast health and breast cancer information. The information presented in tonight's discussion is for educational purposes only. For answers to specific healthcare questions and concerns, you should consult your healthcare provider. So let's jump right into tonight's discussion. So we are going to start with Riverside Health. So thank you so much for being with us tonight, Dr. Javinsky. So as our discussion today focuses on empowered health at any age, in this year's health guide, you mentioned that breast cancer is the most common form of cancer in young women. It is also mentioned that it is the most common in birth. Could you give us a little more information about this?
Sure. And by the way, thank you so much for allowing us to help you and participate in this wonderful event. Now, breast cancer is rare in young women. I don't want to say that it's common. It makes up only 10% of all breast cancers that occur in women under the age of 50, but it is increasing. And it's increasing for a number of reasons. One, due to reproductive health choices and delaying pregnancy, also things such as obesity, which increases as well. And so with that increase, we note that there are certain particular facets about breast cancer in young women. One, since we don't screen women under 40 in general, except if they're at high risk or have a family history or genetic mutation, it's often diagnosed at a later stage. It often tends to be more aggressive. And it also tends to lead to a higher mortality rate or death rate than in older women. And it's particularly prevalent in younger women that are African American. And so we are concerned about this. Women under 40 are nearly 40% more likely to die of their breast cancer than women over 40. And it tends to be more aggressive and diagnosed at a later stage. And it's challenging because of the phase of life that women are under 40 are having with the children and with family responsibilities. And so that causes a lot of challenges. As far as pregnancy-associated breast cancer, yes, breast cancer is the most common cancer in pregnancy, but it is still uncommon. It complicates only about 1 in 3,000 pregnancies. Yet it does lead to increased stress, and breast cancer in pregnancy can be treated successfully, but we have to modify what we do because of the pregnancy status, and decisions relating to what trimester in pregnancy the cancer is diagnosed will lead us to make choices about what the best options and the best treatments for the patient with cancer in pregnancy. But remember, most lumps that develop in the breast in pregnancy are not cancer. They're often related to the changes in the breast during lactation and things of that sort.
Thank you so much, and thank you for that clarifying information. That was extraordinarily helpful. Thank you. That was amazing. Thank you so much. So could you now discuss the importance of advocacy in self-detected breast cancer? And then maybe the next steps if the cancer is detected through self-examination.
Well, the first thing is that you should be aware of your body and be aware of changes that occur. And any changes that occur in the breast should be brought to the attention of your healthcare practitioner. And what are we talking about? If you feel a lump in your breast or under your arm, if you see any skin changes, redness, thickening, a change in the breast shape or size, any discharge from the nipple or scaling of the nipple, those things should be brought to the attention of your healthcare professional. However, you also should remember that screening for breast cancer is really critical. And the new guidelines suggest that we should start screening women of average risk at about age 40. Some suggest 45, with annual screening until the mid-50s, and then a decision to be made whether to screen annually or every other year, and the continued screening up until the time that the woman is no longer functional. And so we don't have an upper age limit on screening. And for average risk women, that's what we recommend. If you're at higher risk, and what puts you at higher risk, we start screening earlier. If you have a genetic mutation, if you have members of your family with breast, ovarian, or pancreatic or colorectal cancer, if you've had radiation to your chest for things like Hodgkin's disease as a young adult, those things will increase your risk and will often enhance the screening and have you screening early. And the other thing to remember is that while family history is very important, 80% of women with breast cancer have either no family history or a remote family history. And so telling somebody I don't have a family history, so I don't really need to be worried, is really not correct. All women should be screened. And if you notice anything, you should bring it to the attention of your healthcare practitioner. Remember, self-awareness is so important in being an advocate for yourself. If you feel a lump, remember, most lumps are benign. And so you shouldn't get overly concerned, but you should bring it to the attention of your healthcare practitioner. The healthcare person should order the imaging studies. If you have a persistent lump, even with a normal mammogram, you should probably have a biopsy, because mammograms miss 10 to 15% of all breast cancers. And so a persistent lump, even in the absence of imaging abnormality, should lead somebody to get further treatment.
Thank you so much for that. You actually have kind of led us into the last question, but I want to open it up in case you have additional information that was extremely informative. Can you discuss ways in which patients can discuss these possible genetic, lifestyle, and other risks with their physicians? Like, can you discuss maybe ways you would recommend that they bring that information, to their doctor's visits?
Well, you should always write down any health concerns and make sure you see a healthcare practitioner regularly and get regular screening. And that includes a clinical breast exam by your healthcare practitioner. And you should know your risk factors. What's your family history? What's your personal history? What's your pregnancy history? And we'll talk about the genetic screening a little bit later, or one of the other speakers will. But, we have a high-risk clinic. We do, at our routine mammography, use something called Tyrer-Cuzick, which is a scoring system which gives us a handle on what's your risk of breast cancer. So what's the risk of breast cancer in the United States for any woman? It's about 12.5%, 1 in 8 women. If that risk is 20% or more, then you're at higher risk. But what can you do to reduce your risk? Well, some of the things we generally recommend are eating well, eating healthy, maintaining a good weight, and regular exercise, avoiding toxins like alcohol and smoking and other things that can increase your risk. There are some risk factors that you have control over, like if you get pregnant, when you get pregnant, whether you take hormones after menopause. And there are some risk factors you can control. Well, first of all, you're a woman. 1% of all breast cancers occur in men, which means 99% occur in women.
Mhm.
When you develop your periods, you have no control over that. Your family history, you have no control over that. If you had Hodgkin's disease or other cancers where you receive chest wall radiation. And so those that are at higher risk, we recommend getting checked twice a year. We alternate the mammography with MRI screening. We also talk about medications like tamoxifen, which is an anti-estrogen, which can reduce the risk of breast cancer in higher risk women, but it has some risks. It can increase slightly your risk of uterine cancer, increase your risk of clots in the veins and in other parts. And then there's also, for the highest risk women, surgical risk reduction, in which we partner with our plastic surgery colleagues and offer risk-reducing mastectomies, which can reduce your risk of breast cancer from whatever that level is to about 1 to 3%.
Thank you so much, Dr. Javinsky. This is such, this information is invaluable. I cannot thank you enough. Is there anything else you'd like to add for our participants before we move to our next topic?
Well, the only thing I would say is be your own advocate. Be the advocate for your health, meaning know your body and make sure when you go to your healthcare practitioner, you mention anything that's going on. Don't just pass it off. It may be nothing. Most of the time it is, but make sure that you know what your risks are and make sure that you advocate for yourself.
All right. Thank you so much. Thank you. Thank you so much for the information. Just so very important. Thank you. So so now we're going to move on. We're going to be talking with Dr. Balanchavitsi from Virginia Oncology Associates. So as our discussion today focuses on the unique experiences of those facing a cancer diagnosis, in this year's health guide, you mentioned clinical progress related to the treatment of triple-negative breast cancer, and we're all hearing about that. So this is very hopeful and exciting news. Could you discuss the characteristics of triple-negative breast cancer? Because I'm not sure that everyone knows what that would be.
Hi, everyone, and thank you very much for inviting me. Triple-negative breast cancer refers to a type of breast cancer that is defined by the absence of key receptors that are expressed on breast cancer cells. And these are estrogen receptor, progesterone receptor, and HER2 protein. And these are the markers that we typically test on breast tumor biopsies or tissues when at the time of surgery. So triple-negative breast cancer is defined by absence of these markers. Typically, triple-negative breast cancers are seen in younger women. About 15% of all breast cancers make up triple-negative breast cancer, are typically more aggressive compared to other breast cancer types, and are more frequently associated with various genetic mutations, such as BRCA gene mutations. And interestingly, because triple negative breast cancer lacks expression of these receptors, therefore, historically, our treatment modalities have relied on chemotherapy because the traditional therapies that we use for hormone-positive breast cancer or HER2-positive breast cancer, such as directed therapies, are not useful since there is lack of those receptors. So these type of breast cancer is particularly challenging because we don't have a lot of tools to combat this kind of cancer.
Oh, thank you so much. I know as someone who went through the diagnostic process, it can be really difficult to kind of weave our way through this and have a greater understanding of what the different types of breast cancer, what they are, and what those different components are. So thank you so much. Could you share some additional information regarding the new hope in treatments? Because I know there is definitely hope out there. We're seeing it. So can you talk a little bit more about that?
Absolutely. I think in the last 5 years, we've seen a lot of advances in treatment of triple negative breast cancer. So it's interesting because we define triple negative breast cancer by things that it does not express, but today we started to focus our attention and our efforts on things that it does express. So we find that there are certain markers, biomarkers that triple negative breast cancer expresses that may allow us target those biomarkers to treat it effectively. That has led to development of several groups of drugs that we use currently in treatment of triple negative breast cancer. And first of such group is immunotherapy. And immunotherapy we use in early triple negative breast cancer before surgery, or neoadjuvantly, as we call it. And we use it in advanced or metastatic triple negative breast cancer. And for those who may not know what immunotherapy is, it's basically a type of cancer treatment that helps the body's immune system recognize and attack cancer cells. So usually cancer cells can hide from the immune system by using certain shields. And these shields are, for example, PD-L1. So basically the immune cells cannot attack cancer cells. And immunotherapy blocks this PD-L1. So immune system kind of says, okay, I see you now. I'm just going to come and get you. So immunotherapy has really revolutionized how we treat triple negative breast cancer. And about 35 to 40% of triple negative breast cancer would express this PD-L1. So pembrolizumab is one of the drugs that is very commonly used both in early breast cancer and metastatic, and has shown that addition of immunotherapy has extended progression-free survival in metastatic cancer, as well as extended overall survival. And it has led to some deep and durable responses. So for metastatic or stage 4 triple negative breast cancer, for those cancer cells that express PD-L1, the standard first-line therapy combines chemotherapy with immunotherapy. So this has been a huge breakthrough. A second group of medications that we use currently in patients with triple negative breast cancer are the PARP inhibitors. So PARP inhibitors are the drugs that block repair system, DNA repair system. So patients that have a problem, inherited DNA repair mutations, for example, those who have BRCA mutations, if there is a problem, a damage in the cell, the body cannot repair that cell normally, okay? But it does rely on other mechanisms on repair. And then PARP inhibitors they basically block the remaining repair system. So when given to those patients that harbor, for example, BRCA1 or BRCA2 mutations, the cancer cells cannot fix its DNA, and it becomes overwhelmed with damage, and those cells die. So in triple negative breast cancer, about 10% of patients would have some sort of mutations, germline mutations, BRCA1, BRCA2, also PALB2 mutations. So these group of drugs, they've not only shown that they shrink tumors, delay cancer progressions, but also they're better tolerated. These are oral drugs. So example would be olaparib or talazoparib. A third group that's important, these are the antibody drug conjugates. So this is kind of like a smart chemotherapy. So it's, chemotherapy acts on every cell. So it's like, spraying chemotherapy to all cells and just killing all the cells. And antibody drug conjugates, it's like giving GPS to chemotherapy. So it just kind of you give direction where chemotherapy should go. So you have an antibody which would bind to the cancer cells. So the antibody is carrying a chemotherapy load. So it has that GPS tracker, so it knows where to go exactly, and then delivers chemotherapy exactly in that area. So what that does, it increases the effectiveness of chemotherapy and reduces the damage. So, and we find that oftentimes these treatments are more tolerable compared to standard chemotherapy. And we have several one of those that are approved by FDA. For example, sacituzumab govitecan that we use in triple negative breast cancer, that has shown that it doubles the overall survival compared to standard chemotherapy. And then I'm sure you've all heard about trastuzumab deruxtecan, also known as Enhertu, which is used in a specific population of patients with triple negative breast cancer that have what we call HER2 low expression. So that's about 40% of triple negative breast cancer tumors would qualify for HER2 low. So leads to significant tumor shrinkage and longer survival. So I think definitely there has been hope, and we have seen improvement in survival, and it will be exciting to see what future brings for triple negative breast cancer.
Absolutely. And, I had not heard of this term before, the GPS piece, and what an excellent way to kind of describe that. So thank you so much. That was such a thorough explanation of these new hope, these potential options in treatment for triple negative breast cancer. So thank you so much for that information. Finally, could you discuss some implications in the treatment of triple negative breast cancer and other forms of breast cancer? What are some of the implications in these development of these new treatments?
Yeah, that's an excellent question. And I think everything is going towards more targeted therapies. So it's not, I tell my patients, chemotherapy is like one size fits none, because you give it and you just don't know how one is going to react. And you give same chemotherapy to 5 different women with same kind of cancer, and they all respond differently. So, and these targeted treatments are really personalized. So, most of the time are more effective and with less toxicities. So I can see the field moving towards earlier use of targeted therapies, specifically in triple negative breast cancer, as in other types of breast cancer. For example, using antibody drug conjugates in earlier lines. As I mentioned, currently we use chemotherapy, immunotherapy first line for those who have PD-L1 positive metastatic triple negative breast cancer. However, those who do not have a positive PD-L1 expression, that's a huge unmet need. So I think that that void will be filled by use of ADCs earlier, and a clinical trial called ASCENT-03 was just presented at ESMO conference about a couple weeks ago. I believe that antibody drug conjugates like sacituzumab govitecan will kind of move up in the first line setting. Also combining antibody drug conjugates and immunotherapy earlier, I think, could be a second path or prospect in the future. And so combining another antibody drug conjugate such as datopotamab deruxtecan with durvalumab. We have a clinical trial at Virginia Oncology currently in the neoadjuvant setting using these drugs. I think as well in that metastatic setting, we're going to see as early data from ASCENT-04, which combines sacituzumab govitecan with immunotherapy as promising. And then I think we're going to start seeing, targeted therapies with less toxicities. For example, there are newer generations, so to say, PARP inhibitors, like PARP1 selective inhibitors, such as suraparib is being studied currently, which we hope that it would reduce the side effects like low blood counts, allow longer treatment duration, and hopefully allow safer combination with other medications such as antibody drug conjugates. And then I think newer generation immunotherapy is coming too, also called as bispecific antibodies. And these are kind of like, I caught this drug like matchmakers, they take the, immune cell, and then they take the cancer cell and they said, we got to meet, and then just kind of put it together and activate T cells, remove tumor immune suppression, and potentially restore response even after prior immunotherapy stops working. So, and you have an ability to use different targets. For example, you can cut off blood supply to the tumor by using VEGF inhibitors, for example, and then have an immunotherapy arm. So kind of become more and more specialized as we go down. And then, I think our understanding is growing. And as more people are learning and we increase awareness. So I'm hoping that our increasing knowledge will drive these next generation drugs, and then also sequencing, because that will be huge. When do you use which drugs and what do you, it's almost playing chess every time I have to choose the next line treatment. So I think the future is exciting, and I'm hoping that as we improve care, and as our hope is, if we cannot cure cancer, at least we kind of make it into a more like a chronic disease process. We improve the quality of life of men and women that we treat, to allow better quality of life.
Thank you so much. I'm furiously taking notes, and then I was like, okay, but we've recorded this. So for those of you out there also that feel the same way I do, such great information from both of our two panelists so far. Thank you very much. So wonderful information. So we are going to move over now to Shartika from Myriad Genetics. So as our discussion today focuses on breast cancer and genetics, could you discuss the difference between genetic ctDNA and somatic testing? And thank you again to VOA for their excellent information. Shartika, can you answer that first question for us?
Yeah, of course. And once again, thank you for having me and the rest of this amazing panel for this wonderful education session. To speak to that, these words, genetic, genomic, somatic, ctDNA, they get mixed around in our heads, and I think the definitions feel like they overlap, and are they the same or are they different? So let's take a step back and just kind of remind ourselves of what each of these words actually mean, right? And what they mean for, testing and the implications for management and treatment for breast cancer. So as you probably know, cancer in and of itself, in its way, is genetic because it's a buildup of mutations within a tumor, within that confined set of cells. But most of the time, those mutations that we're talking about are truly only confined to that tumor itself. It's not something that's being passed down from generation to generation. In other words, most cancer is sporadic or random, happen by chance. There's only a small subset of cancers that fall into this category that we might actually call genetic or hereditary. So when we talk about genetic testing, typically what we're referring to is looking to see, was I born with a mutation in a gene that we all have, that normally is responsible for protecting us from developing cancer, but because of a mutation or an abnormality in that gene that renders it non-functional, it's no longer able to do its job the way it's supposed to. And therefore, these mutations have a propensity to build up a lot faster, and a cancer may develop at a younger age, or a rare type of cancer might develop, or we might see more than one type of cancer in one individual or throughout the family. When we think about that, we're thinking about, again, something being passed down from generation to generation. And so we're oftentimes seeing a family history of cancer. Or Dr. Chavinsky was talking about young ages of diagnosis. One of the reasons that we might see younger ages of diagnosis in a family is due to hereditary or genetic causes of breast cancer. So there's a number of genes that I'm sure many of you have heard of before. BRCA1 and 2 have already come up a number of times, but there's a number of other high risk and moderate risk and even lower risk, but still increased risk over the general population that warrants increased screening or potentially surgeries or just different types of management over what we might do compared to the general population. When we're doing genetic testing, we're looking at our normal cells, not the tumor, but just the regular cells in our body. Now, that's different from somatic testing. So I'll skip ctDNA for just a second. Somatic testing, where we're actually doing or looking at the genetics of the tumor itself, where we're looking to see, hey, how did this cancer in and of itself form? What does it look like? What are the genetics or the biomarkers that we're seeing in the cancer? And can we use the genetic or the genomic or the somatic information to guide therapy options? So Dr. Balanchivadze talked a lot about these targeted therapies and how that's truly the future of cancer treatment, right? Being able to pinpoint exactly what's going on in that tumor and really target that cancer so that we're not just kind of going blindly into treating that patient. We're really focused on, the why of the cancer and not just the where of the cancer, if you will. And so doing somatic testing helps us to identify, could this patient be eligible for one of those immunotherapies or for one of those antibody drug conjugates or any of these other kind of targeted therapies. And to the point of our past speakers, we're doing that somatic testing earlier and earlier in that treatment journey so that we can have more insight into what those therapy options might look like. Circling back to genetic testing, again, the hereditary causes of cancer, there are, of course, therapeutic options for that category as well, namely PARP inhibitor therapies for those patients who were born with a BRCA1 and 2 mutation. But you can kind of see how it's all integral to cancer care in 2025. Now, typically with somatic testing, the standard right now is to obtain a tissue sample and to do genetic testing on that sample itself. but this segues into the ctDNA discussion, which is the ability to actually look at ctDNA, which stands for circulating tumor DNA, which essentially is the DNA that's sloughed off from the cells within the cancer itself and basically circulate around in our bloodstream. And so it allows us to look at the genetics of a cancer without ever taking a biopsy or without ever having to do surgery, without needing that tissue sample. There are definitely limitations to that sometimes if we don't have adequate circulating tumor DNA, if the levels of that DNA are much, much lower in the bloodstream. Certain cancers are going to slough off a lot more DNA than other cancer types, but it allows us to get some insight into what that cancer looks like, again, without actually having to take tissue. And so we're certainly seeing that happen more and more. I would say with the ctDNA, there's probably kind of two reasons in the cancer care world that we're really using that technology right now. One is to assess for targeted therapies in the similar way that we're doing somatic testing. And again, I'm kind of using them one and the same. It's just more so the technology that we're using to obtain that information. But one of the more recent things that's kind of happening is using ctDNA technology to look for recurrence or metastasis at really, really low levels after a patient has undergone therapy. And that's called minimal residual disease. And so we're seeing that happen more and more in the monitoring of cancer after treatment to guide those next steps while a patient is potentially in recurrence. All of that to say, it's really important and all slightly similar, but all very different.
No, thank you so much. What a great explanation. I cannot thank you enough for that. So I'm going to actually combine the next two questions because I think they're kind of, you'll be able to answer them together. How often do you recommend that an individual be retested? Because I know that genetic testing has progressed and we keep adding pieces to it. And then, do you recommend that family members be tested as well?
Yeah, so really great question. Genetics is constantly evolving, no pun intended, right? So when I was in the clinic, I would typically tell my patients, reach out to your provider every 3 to 5 years, because there very well could be new updates that are available on the last set of genetic testing that you got. That being said, if you had a set of genes tested back in, I don't know, 2010, your genetics don't change. And so you don't need to be retested for those genes again down the road. But to your point, there could be additional genes that we've since discovered or now have evidence for and guidelines and management recommendations that warrant taking a second look and getting update testing for those additional genes for which we didn't have technology back in the day. I would specifically say if you were tested before 2010 or even 2013, you probably only had a handful of genes, probably didn't have a full multi-gene cancer panel. And so that's certainly a reason to get expanded genetic testing, because these days panel testing is really the standard of care. But then from there, again, every 3 to 5 years, check in and see what's new in the world of genetics. For family members, in a perfect world, we like to test the person who's had the cancer diagnosis first, right? Because the question we're trying to answer with all of this is, why is there cancer in my family? What is explaining all of this? Is there this level of heritability that could help me and my family guide the next steps for management and treatment? But we know that that's not always possible, right? And so if you have the ability to get genetic testing, always good to talk to a genetics provider or a healthcare professional who can take your family history and guide you through what your genetic testing options are. If we know that there's already a mutation in the family that is indeed germline or genetic, the inherited kind, then that warrants genetic testing as well. So that could be a first, second, or even a third degree relative. If it's a fourth degree relative, maybe insurance isn't going to necessarily cover that, but we can start to think through the family history and be more cognizant of that. I think a lot of times we get confused about somatic testing and genetic testing. And so there's always the possibility that we've heard of a family member who had somatic testing looking at the tumor, and there was a mutation there, but it's not necessarily inherited. It's not necessarily something that was in that person's normal cells. So it's always good to clarify that as well if you can. Always good to get a copy of that test report to make sure that we know exactly what we're supposed to be looking for, and then absolutely get cascade testing. And that's what we call testing of family members once we found that a mutation in the family.
Thank you so much, Ratika. Such amazing information. I have a feeling there are going to be lots of questions. So thank you so much for being with us and sharing this this information. So we're going to move now to VCU Massey Comprehensive Cancer Center. I know that we have Dr. McGuire with us. I believe that we might also have Dr. Ziaris with us. So if you want to take turns answering, if both of you are here, or one can just answer whatever you feel most comfortable with. So as our discussion today focuses on the technique of resensation, which I know is new, well, new to a lot of us hearing about it, I'll just say that. Could you explain more about what that is? And then also in that discussion, the developments of that. Thank you and welcome.
All right, well, I'll start off and then I'll hand it off to Dr. Mountziaris. But yeah, so resensation is the concept that when a woman has a mastectomy, and often young women will either require or desire a mastectomy, whether that's because of the volume of disease they have within their breast, a genetic mutation, or just a desire to have a mastectomy rather than a lumpectomy, which is their choice when they're faced with a breast cancer diagnosis. And so what we know is that we've made incredible advances in the cosmetic outcome of breast reconstruction. So we make breasts look like breasts. We make breast mounds that look like breasts. We can do nipple sparing mastectomies, skin sparing mastectomies, and to all of the rest of us, those patients look great. But to those patients, if they can't feel their reconstructed breasts, then they never feel as great about it as we think they might. And so that was where the concept of resensation came in, and it comes from a concept within plastic surgery of nerve grafting that I'm going to let Dr. Monsiaris talk about. But the long story short is that a few pioneers took that technique of nerve grafting and have used it now to nerve graft sensory nerves back to the breast mound during reconstruction to help preserve some sensation. And so is it going to be the sensation like what most women have walking around today? Absolutely not. It's sensation that allows you to feel like your reconstruction is more a part of your body, to have better sort of self-awareness, and to have some safety too. So I always tell them it's like avoiding that Mrs. Doubtfire moment, which is rapidly becoming a sort of an unfamiliar territory for a lot of younger women. But really, we've had patients who've had burns or frostbite because they can't feel their reconstructed breasts. And so it's not only something that's great for body image and self-awareness, but also for safety. And I'll hand it off to Dr. Monsiaris to talk about how this all evolved.
Well, thank you so much. And, Dr. McGuire, you've actually answered the psychological well-being question when you did that. And I thank you because thank you very much, because that is such an important aspect and not often talked about. So thank you. Okay, so we'd love to learn a little bit more about the technique and the developments.
Sure. Well, I'll start by saying that a lot of us in the breast cancer world and in breast cancer reconstruction just sort of take it as a given that a woman's going to be numb after a mastectomy. And, a lot of people don't give it much more thought than that. But being numb isn't the end of the story. Like women aren't necessarily numb. They have nerve damage, and nerve damage can hurt. Nerve damage can give you weird zinging sensation. Nerve damage can come back a couple years down the line, 10 years down the line, and start giving you chronic pains. And women show up to my office, and I'm sure to other providers' offices, saying, now my breast hurts. Is my cancer back? Like they're freaked out about it. And they have these reconstructed breasts that, like Dr. McGuire said, may look beautiful, but don't feel like they're a part of them. So the technique first started with women who were getting reconstruction with their own tissues, so free flap surgery. So women undergoing deep flaps. This was pioneered by Dr. Spiegel. She's a plastic and reconstructive surgeon in Houston, Texas. She started reconnecting nerves to that tissue that she was transferring to build a breast mound. And women were getting feeling back, both feeling at the skin and feeling of like pressure, temperature, feeling a hug rather than just knowing that someone's hugging you and then there's this kind of numb, maybe painful thing that looks like a breast on your chest wall. And about 5 years later, maybe, so about 2018, the technique kind of got turned over to, well, what if, most women in this country get implant-based reconstruction. What if we do this reconstruction so that we give the skin feeling? And so women who even have an implant as what's giving shape to their reconstructed breast can have the benefit of this. Now, all that being said, I will say that now in 2025, fewer than 1% of women nationwide are having this procedure. And part of it is because people don't know about it. And part of it is because we in the plastic surgery community aren't offering it to our patients. But, I was trained in nerve reconstruction in a variety of other areas. And Dr. McGuire and I got together a few years back and she said, hey, what do you think about this? And I said, I think it's great. And we started talking to the patients and they said, what's the worst thing that could happen to me? And I said, the worst thing that could happen is this doesn't work. And you wind up like the other women who have mastectomy and we didn't do anything. And what's the best thing that could happen? You could get some feeling back. You could get a lot of feeling back. You could start to feel like your reconstructed breasts are more a part of you, which kind of speaks to psychosocial and psychological well-being. But also I have patients who like their bathing suit slipped and they didn't have sunscreen in the area and they got a terrible blistering sunburn and they didn't realize it until they looked down and they show up and it's like this terrible wound or they splattered themselves cooking. Or like Dr. McGuire said, we had one lady who was icing her chest because, something hurt and she didn't realize she left the ice pack on too long. She got frostbite. Like, that's not cool. Like that goes way beyond, sexual and, psychosocial well-being into just basic, safety. And so we started doing the technique and, we offer it to a wide variety of our patients. And I would say that it's working and it works to differing extents in different people. And, everyone who's involved in this type of procedure is still trying to figure out how can we predict who it's going to work the best for and who it's not going to work as well for. But, from my standpoint, and I think from the standpoint of a lot of patients who come to see us, it's worth a shot. So the only people I wouldn't recommend it for, I would say like it's a hard stop, we're not going to do it, are people who are so frail or fragile that like that extra 30 minutes to an hour under surgery is just not safe, which isn't, by and large, knock wood, are here for the girls' younger patients. It's, our more elderly, frail patients.
This is, I mean, wow. What an amazing development this is. I mean, it really is, and I've heard people talk about this and the positive psychological impacts. So thank you so much for also bringing those. Could you speak to those just maybe a little bit more, and then also tell us, how someone would go about taking that step if they wanted to? Like, what would that discussion look like?
Well, I'm typically the one who sees the patient first, so I can talk a little bit about how that discussion goes, because I would say it's still something that most patients are not aware of. So I think, I think that if a patient is interested in it, especially if they're thinking about a prophylactic surgery or something along those lines, then the first thing they need to do is seek out somebody who is doing that procedure, and that is available information online. But the first question to ask is, am I a good candidate for it? So like Dr. Monsiora said, There are very few patients who are not a good candidate for it. It's very similar to what, and the surgeons on this Zoom will understand. It's back when we started doing nipple sparing mastectomy. We were so hyper selective as to who we did nipple sparings on. You had to have the tiniest little tumor, and you couldn't have been getting neoadjuvant chemotherapy, and the tumor had to be, miles away from your nipple, and there were all of these caveats. And that's really how these techniques start, and then people start to gain comfort with them and find that most patients are adequate candidates for a procedure. So patients, that's the first question I think they need to ask is this something that you think I'm a good candidate for? And then I think that the next question is, is asking about the particulars of it. How much longer am I going to be in the operating room? What's going to be the post-op care? There are definitely things that a patient can do after this operation to try to improve the development of resensation in terms of some little exercises they can do and things like that. And then I think then, the other question is, if they're, they also need to consider whether they're going to have an implant-based or a tissue-based reconstruction, because if they're ultimately going to have a tissue-based reconstruction, then Dr. Monsiaris can speak to this, but I think the much better option there is going to be resensation of the flap rather than of the skin. So there's lots to talk about within that conversation. And I think a lot of it actually ends up, we start talking to the patients about it, and they are just have no idea that it even exists and are very happy to hear about it as an option. So then it usually takes a second conversation to be like, I was really excited about this, tell me more. And so it's not a, with any breast cancer consultation, it's not a, let's get all those questions asked the first day. It's, write them down, think about things, and come back and ask. I think one of the more significant barriers we've had is with a few insurance companies, as always, considering this experimental. And so that is another question to ask your surgeons is, how are you going to work with my insurance company to make sure that this is covered?
Absolutely. And like I said, we've heard some discussions here and there about it from people, and I keep going back to this psychological well-being, as well as the physical well-being, but the impact, I don't think we can state that enough, the impact of that. Is there anything else that you'd like to add? Anything about the technique or anything like that that we need to know? Because maybe I don't know what to ask about that isn't listed on here. Is there anything else that you would like to add?
I would just second what Dr. McGuire mentioned, that there is information and there are resources online, including, a way to find doctors in the area who already are saying that they offer this procedure. And so if you're already, a patient in a certain health system, this may help to clarify, oh, I'm seeing, Dr. Monsiaris, obviously I offer this procedure, and those who are on this, webinar today know that, but the patients don't have to be on the webinar. The internet is both dangerous and wonderful, and it's got this information. So it can also help people to formulate some questions. I also, after I meet with the patients, will refer them to websites that I think are a good resource and have good information so that they can sort of stew on things and have that to refer to, rather than just whatever notes I make for them. Maybe there's something, on that website or in patient testimonials that will sort of spark a question or help them to understand things in a way that maybe I didn't make quite so clear. But like Dr. McGuire said, usually the patients are seeing the cancer surgeon first. So that's where the conversation starts. And then by the time they get to me, we're just talking about, the ins and outs of it, and I'm the one who's fighting the insurance and all of that wonderful fun stuff. So,
Well, but thank
is-
you for doing that.
but unfortunately, that is still a reality of it. And so there is an insurance approval process that these patients are going through, and unfortunately, some insurances are just way more painful than others.
Well, thank you. Thank you both so much for bringing this to the table and to the discussion. Something that not as many people have heard about. So thank you very much. So we are now going to move to our, we have two more panelist groups, and then we will take questions. So thank you very much, VCU Massey Comprehensive Cancer Center. So we're going to move to Dr. Jablonka and his team at North Beach Plastic Surgery. So Dr. Jablonka, as our discussion today focuses on reconstruction, could you discuss the different types, give us kind of just a brief discussion about the different possible types of reconstruction? And thank you for joining us.
Sure, absolutely. And thank you for having me. One thing I want to do is I think I want to brag on Dr. McGuire and Dr. Montziaris. You know, resensation is a very cool thing that we're adding to our reconstructive services. One big thing that you need is a wonderful team. You need a great partnership between a breast surgeon and a plastic surgeon who believes in that procedure, knows how to respect the nerves, because we're trying to find these nerves to reconnect, and respects tissue planes in order to be able to execute these surgeries successfully. So I think it's pretty cool. You guys got a good thing going on over there. So yeah, I'll touch a little bit on breast cancer reconstruction. Okay, in our practice, we do quite a bit of breast cancer reconstruction. We do offer the full breadth of reconstructive services, not just breast cancer reconstruction after mastectomy and lumpectomy, but we're also starting to offer reconstruction after lymphatic surgery or after axillary lymph node dissections, which I'll touch upon a little bit. But first, I want to say that the goal of breast reconstruction is to rebuild breast mounds across the chest that are as symmetric as possible, so a woman can look normal in clothing, so they can feel very normal in clothing. Of course, we do a number of different techniques to try to hide scars and make women look normal outside of clothing, right? There are different techniques that we can do to do that. But again, the ultimate goal really is to really restore the shape of the breast after a mastectomy or a lumpectomy that's been performed for either the treatment or prevention of breast cancer. Okay. Now, I will talk about, so how do we rebuild the breast after a mastectomy? Well, there's two main ways we do that. You can either use implants or you can use your own natural tissue. Okay. So with implant-based breast reconstruction, we typically use a saline or a silicone device or breast implant. This can be done in either a single stage in what we call a direct-to-implant. This is where at the time of the mastectomy, the permanent prosthetic or permanent breast implant is placed at the time of the mastectomy. So you wake up with your quote unquote final reconstruction. But it can also be done in two stages where a temporary device is placed at the time of the mastectomy. This is called a tissue expander. And this device is designed to gradually expand and stretch a skin pocket over time. Once that pocket is stable, we then go back to the operating room to have that tissue expander removed, and then this is replaced with a permanent device. Okay. Now, the other form of reconstruction is where we use a patient's own tissue, right? We call this autologous reconstruction, right? Autologous meaning your own tissue. We call it flap reconstruction. This typically involves either the transfer or transplantation of tissue. It does on occasion require microsurgical skills to execute these transplantations. We will transplant excess skin, fat, sometimes muscle from another part of the body into the chest, where we will reconnect arteries and veins to keep this tissue alive. We can use this tissue to then reshape and rebuild a long-lasting natural breast, again, made of a patient's own tissue. Typical areas that we borrow tissue from, actually the most common area we borrow tissue from is from the lower abdomen. This is what's called deep flap breast reconstruction, which I'm sure many people who are attending this event today, they've probably heard of deep flap breast reconstruction, but we can borrow tissue from other parts of the body. We can borrow from the back, the buttock, the thigh, even the love handle, which is it's a pretty new way that, new alternative to tissue reconstruction. It's called a lumbar artery perforator flap. It's a little bit more complex. It requires artery and vein grafting occasionally to execute these surgeries, something that we've been offering in our practice. I'm very excited about it because some of these patients who are traditionally not tissue candidates, where they don't have a belly, but they hide a lot of their fat in their love handle, we can use that tissue to rebuild the breast after a mastectomy. Occasionally we use combination, or hybrid techniques where we use both tissue and implants to rebuild the breast. Occasionally, we have to do that for patients in order to build a long-lasting, stable breast with good aesthetics. We may need to use flaps and implants to do something like that. There are adjunct procedures that we offer, such as fat grafting, which can be incredibly powerful with improving contour across the chest. We also talk about nipple and areola reconstruction, and 3D tattooing is quite a popular, many of my patients, pursue 3D tattooing as a way to really refine the cosmetics of their final reconstruction. One thing I want to add that we've been offering just this year is what's called immediate lymphatic reconstruction. This is very exciting. This is where patients, and what we've been doing is we've been offering it to patients that have node positive disease. We know that they have node positive disease. We know that they're going to require an axillary dissection as part of their breast cancer treatment. And so at the time of the mastectomy, what we do is mastectomy and axillary dissection. What we can do is we can reroute the lymphatic vessels from the arm that preferentially drain lymphatic fluid from the arm that have now been disturbed because of the axillary dissection, and we can reroute those into nearby veins to help that lymphatic fluid bypass the axilla or the armpit. That way we are trying to prevent the development of lymphedema, or that chronic swelling that you can get after an axillary dissection. We're trying to prevent the lymphedema in the upper extremity. This is something I'm very excited about. There is some preliminary data that's come out of Memorial Sloan Kettering. They've been doing this for the last 5-10 years, and the results are really impressive. They're showing a reduction in the development of lymphedema in these patients, again, undergoing immediate lymphatic reconstruction after axillary dissection. The rates are decreasing from 30% to about 10% in these patients. So these are all the different reconstructive options that we offer, both for the breast and for lymphatic surgery.
Thank you so much. I mean, we're just going to have In the Know every week, because you all have brought so many amazing things to the table. Thank you so much for that information. I had no idea about the reconstruction with the lymphatic system. So thank you. Could you now tell us just a little bit more about, first, is there anything in that one would need to consider into making decisions? And then second, any recovery and outcomes, pieces that would kind of factor into that decision, as to which reconstruction path.
Yeah, sure. Everyone is very different. Okay. Everyone's very different. And when we're deciding on the type of breast reconstruction, which is best for our patients, there are a number of different factors that we consider. Certainly medical factors, there's personal preference, and also lifestyle considerations. Of course, the cancer treatment, whatever the multimodal cancer treatment protocol that they're undergoing can certainly affect options, particularly when radiation is part of the treatment protocol. It is well known that radiation therapy to the chest can certainly increase implant-related complications. So implants aren't always that favored in a radiated chest. So we tend to open the discussion, the possibility of using a patient's own tissue to rebuild their breast. It tends to fare better long-term when radiation is involved. Of course, timing of a reconstruction is something else we will also consider. With immediate reconstruction, what that is when reconstruction is performed at the time of the mastectomy. This has been shown to be able to obtain or achieve better cosmetic results in fewer surgeries. However, sometimes we have to delay the reconstruction, right? Particularly if there are adjuvant therapies, chemotherapy, radiation after the mastectomy, where a patient we want to just treat the cancer up front, get that taken care of, and then we'll revisit rebuilding the breast at a later date. So sometimes that's a safer option for many of our patients. Of course, when deciding on whether or not what kind of reconstruction you're interested in, whether or not you want to use your own tissue, or if you want to choose implants, of course, anatomy matters, right? Does a patient have adequate donor tissue? Do they have enough tissue on the belly or the thigh or the love handle to be able to execute flap reconstruction? For patients that are not, they're likely better served with an implant reconstruction. Of course, health issues. There's certain health issues that can affect whether or not a patient should have reconstruction, or if they do, which is safer. Patients that are smoking, obesity, diabetes, these comorbid conditions, which certainly can affect or increase your risk of wound healing complications after surgery, can ultimately, they can also play a factor in whether or not a patient even decides on whether or not they want reconstruction. And then when discussing the different reconstructive options, right, just the nature of the surgeries themselves. For example, flap surgeries. These are big, complicated surgeries, or they can be. They can be big, complicated surgeries with longer recovery. There's a secondary surgical site you typically need to recover from, right? And so restrictions tend to be more severe and for a longer period of time when compared to implants. Implants tend to be, shorter downtime. However, it's not uncommon that patients may need future surgeries they were not planning on to help maintain the reconstruction or switch out the implant. So, and then finally, aesthetic goals, setting aesthetic goals, what's important to a patient when rebuilding or restoring the breast, how important it is to have a more natural feel, addressing symmetry, and also nipple reconstruction if that's something we have to tackle. So.
Absolutely. Thank you so much. Thank you very much, Dr. DeBlanca. We so appreciate the information, especially the information about the lymphatic reconstruction. Thank you. So we are we're going to move to Dr. Wilson from Sentara Health. And just to let everyone know, we did start a few minutes late, so we will go just a few minutes after, regarding the questions and answers. And again, the questions and answers that we don't get to, we will absolutely send out. So thank you so much for being with us. So as our discussion relates to breast cancer and secondary cancers, can you share a bit more information about how receiving a breast cancer diagnosis due to genetic variants, a genetic risk, could be a risk in developing a secondary cancer?
Yeah, I would also echo, thank you so much for the invitation and getting this group of people so interested in providing education and taking care of people with breast cancer. So I appreciate the invitation. There are a number of genes, 10, 15 years ago, we really were just talking about BRCA1 and BRCA2, but now, right, she was talking about, we do all these multi-gene panels. And I will tell people all the time, it is very possible that we're going to do genetic testing because you came in and you're young and you have breast cancer. And this has happened to me a couple of times in the last few months, where I may wind up telling you, what, your family history is actually, or your genetics increase your risk of prostate cancer, which does you absolutely no good, but you need to be aware of that, for your family. BRCA1 and BRCA2, not only is important to think about your risk of breast cancer, but they increase the risk of ovarian cancer. They increase the risk of more aggressive, potentially prostate cancers, pancreas cancers. So there are a number of other cancers that we need to think about besides just perhaps the cancer that we're already thinking about.
Absolutely. Thank you so much. And can you tell us a little bit about maybe a possible increased risk of secondary cancers due to treatment of breast cancer? Can we talk a little bit more about that?
Yeah, the good news is that most of these are uncommon, but they certainly can happen, and so they're important for us to be aware of. One of them was mentioned way at the beginning, where we were talking about tamoxifen. Tamoxifen does have a slight increased risk of endometrial or uterine cancer. So that is something that I always tell people about before they go to the oncologist to think about those medications. Radiation can actually increase the risk of, again, they're super uncommon, but there is a very specific radiation-induced sarcoma that can happen. We already kind of talked about not so much breast, but having radiation from childhood cancers can increase your risk of developing breast cancer. So it is important to think about, with these treatments, what other cancers could be something that we have to think about.
Absolutely. And then finally, what screenings or follow-up would you recommend, Dr. Wilson, that would help evaluate these potential secondary cancers?
So it's for the ones that are either treatment related or gene related, just making sure you have good follow up with your surgeon and your oncologist, are going to be the main things. But then the good news with all of these advances that we've talked about, right? People are being able to live longer. We're able to have more people that can, have cures of their cancer or potentially, live for years. And so it's important to remember, all the other things, right? Sentara was fortunate to have Dr. Funk, who's a very well-known breast surgeon from Los Angeles, here a week or two ago. And one of the things that she said that I thought was really worthwhile was, this is an opportunity to kind of reevaluate everything when you get this big diagnosis. So it's a chance to think about all those lifestyle things. It's a chance to think about, alcohol. If you're a smoker, it's your chance to, this is my time to stop smoking. It's a chance to reassess your diet, to try to think about all those healthy lifestyle things. But it's important also to remember, if you're of age, get your colonoscopy. We're starting to see people that are younger that are developing colon cancer. So get your colonoscopy. And I will tell you, I did it as soon as I was eligible. If you're a smoker, think about getting those lung screening lung CT scans. One of the great things in the summer here is the ability to be outside. But if you're going to be out in the sun, make sure you wear sunscreen. You do all those things that you can to try to protect you from getting melanoma. And if melanoma runs in the family or you've gotten a lot of sunburns, you may want to think about, seeing a dermatologist.
Dr. Wilson, I really, and it wasn't even one of your questions, I love what you brought to the table. And that is, this is the opportunity to take a look at our lifestyle, right? And what we eat or other factors in our life and how do we reflect on that? Thank you so much. That was a really important piece of information. Is there anything else that you think would be important to add before we move on to our questions and answers related to this topic?
I heard rumor that there was a question pre-submitted that was related to breast cancer and thyroid cancer. I can find some data that suggests that there is a very specific gene predisposition that has thyroid and breast cancer on it that could come up with genetic testing. But I did find, that it's kind of a bit conflicting and it's not totally clear like what the etiology is. But the most likely is that it actually does probably come back to lifestyle, some of the same lifestyle things that increase the risk of breast cancer, increase the risk of thyroid cancer. One, they're both more likely to happen in women. They're both more likely to happen in those that carry extra weight. And so, as I say, it's a lot of this we really try to come back to, like, try to live the best life we can to try to help prevent cancer.
Wow. Thank you so much. Thank you so much for sharing that. I want to take just a moment before we move into the questions and answers to thank each and every one of our panelists. I know that you get up very early in the morning and work very late at night. So to have you at all this evening has been a true gift. So what we're going to do is we're going to move into the question and answer period. Chris, just so you know, I only see a couple right now. So if there are others that if they're, I think they're coming in now. So we'll start at the beginning, and then if it's specific to an individual, if they want to chime in, and then if not, if others want to answer as well. So one of the, thank you, Dr. Wilson. You answered the very first question. What is the correlation connection between thyroid and breast cancer? So it looks like we already have a response to that question. So we'll move on to question number 2. Number 2 is I've had the genetic testing done when I was diagnosed with breast cancer, and it came back as no known mutations. Is it possible for me to have another one done? And will insurance cover it? Because different types of cancer run in my family. And then our participant talks about the different types. I think this was mentioned earlier about how genetic testing does change over time, or the number of things we can test for. But Shartika, would you mind responding to that question?
Yeah, absolutely. So again, always worth reevaluating what your personal and family history looks like now versus what it looked like then. And also with the knowledge that genetic testing guidelines have really evolved over the last even just kind of 2 to 3 to 5 years, where more and more patients are now eligible for genetic testing where they weren't before, which could mean that based on these updated guidelines, your personal or family history now opens the door for additional genetic testing that you didn't necessarily meet criteria for the first time you had genetic testing. That being said, if there aren't differences necessarily in kind of meeting eligibility criteria, insurance companies are fairly good about covering update testing. And I know most genetic testing laboratories as well won't balance bill patients should they seek to get a larger panel compared to the one that they got previously. And if for whatever reason it's not covered or that's not an option, most laboratories also have a very low self-pay option for patients as well and really great financial assistance.
Thank you so much. These questions are amazing, by the way, that are coming in. So I'm going to try to get through as many as I can. Thank you very much. So, Dr. Wilson, this will be for you again regarding secondary cancers. Is there a way to determine if the secondary cancer was a direct result of the breast cancer treatment? Dr. Wilson, I'm
The
not sure
short
if you're.
answer is, I think it would be hard to necessarily know for sure. Um, if you got a radiation-induced sarcoma, after you had radiation, then that almost certainly is going to be from treatment. If you were on tamoxifen and you got uterine cancer, did you get it from the tamoxifen or did you get it from the fact that you were going to get it anyway? That one's a little bit harder.
Okay, no, and that's a very valid answer. Thank you so much for that. Oh,
add to that as well in regards to chemotherapy. Certain chemotherapy agents that we give do carry risk of therapy-related myelodysplastic syndrome and therapy-related leukemia. These are our anthracyclines, such as, also known as the red devil or doxorubicin. There's cyclophosphamide and the platinum drugs. So basically the whole cocktail we use in that Keynote 522 regimen for triple negative breast cancer. Thankfully, that risk is low, less than 1%. And typically the way to tell would be, these type of findings would develop, anywhere 2 to 10 years. And then there are characteristic findings on the bone marrow. We do the kind of like genetic testing of those cells as well. And we find that those cells may have certain mutations, or we call it, complex karyotype, meaning some changes within the cells that would point to therapy related. We did mention the thyroid specifically, in older times, they would radiate the filled upper. So, thyroid cancer risk, but nowadays that's lower. And then I think everything else, PARP inhibitors have been associated with some risk of MDS as well. So, those are some of the ways one can tell.
Thank you so much for that added information. Thank you very much. I'm going to come back. I see 2 questions that'll be for our surgeons, but since we might get multiple answers, I'm going to ask, skip down just for a minute, because this will be from VCU. Can resensation procedure only be done at the time of the mastectomy, or can it be done in future reconstruction surgeries such as exchange or revision surgeries? Great question.
Unfortunately, the answer is it can only be done at the time of mastectomy. I've talked to some other colleagues at meetings. There are some folks who are trying to look into, this is obviously a big question because, like I said, only small minority of women are getting this procedure or even having the opportunity to get this procedure at the time of mastectomy. So the question is, how can we expand this to patients who have already had their mastectomy and we're going back in? Unfortunately, there are changes that happen in our spinal cord and in our brain when nerves are damaged that can become permanent with time and that cannot be overcome. This is especially studied in patients who have strokes and in our amputee population, but this is of course also true of our patients who are getting, a different amputation of sorts, and that's a mastectomy. So even if we overcome some of the technical challenges, we may not be able to overcome the fact that these nerves are simply fried in a way and just won't restore and regenerate and give that feeling and communicate with the brain in a normal pathway.
Thank you very much. Thank you. Dr. Jablonka, I'm going to ask you the next question, then I'll open up the follow-up question to any of our surgeons. Dr. Jablonka, can you tell me, is there a way to determine if autoimmune symptoms are a result of, or I guess if breast implants can impact autoimmune symptoms is the question.
So that's a great question. I would say that this was studied extensively because, a few decades ago, there was actually a moratorium placed on breast implants back in the late 90s, looking at whether or not breast implants had anything to do with causing autoimmune phenomenon, autoimmune diseases, or even cancer. And since then, it has been found that that's not the case. So to answer that question, does it cause autoimmune disease? I think the answer is no. Is there a way to measure whether or not is there a marker for this? The answer is no. However, there is something that's been getting a lot of traction and a lot of publicity, and that is what's called breast implant illness, or BII, which is essentially a seemingly unrelated constellation of symptoms that have been worked up extensively to find no organic cause. And some of these patients that have suffered through this breast implant illness are convinced that maybe it's likely related to their breast implants, right? That all of these symptoms started happening once their breast implants were placed. Were placed. Now, what's interesting about this is that it's hard to diagnose. It's essentially a diagnosis of exclusion. But what I will tell you is we do see patients that come to our practice looking to have their implants removed because of these problems. And surprisingly, many of these patients, and this is all anecdotal, when we go to remove their implants, that it's within sometimes even in recovery, that they think that their symptoms have resolved. I mean, it can be within 24 to 48 hours. This is an area of focus that a lot of research is going into to try to figure out what this breast implant illness is and what the causes are. But that's probably a long-winded answer to saying that we don't think it does. But this new breast implant illness is an area of study that certainly needs some explanations.
Thank you so much. So in the interest of time, we're gonna stop at 8:35 because we want to give our doctors time to rest before they go back tomorrow. But we can also send these questions. So we have time for a couple more questions. So there was a general question about how often should breast implants be changed out, I think was the actual question. Or replace. I don't think it was replaced. I'll have to look.
Sure. Maybe Dr. Montanziaris might want to chime in on this too, because breast implants, there's two components to a breast implant. You have the shell and then what it's filled with. Okay. So when you hear a silicone implant, that is a shell that's filled with silicone material. Saline implant are shells filled with saline, right? So the idea of replacing implants are really for the silicone devices. Okay. Now, silicone devices have changed over the years. There's been different generations of breast implants or silicone breast implants. And when they change from generation to generation, they're changing either the shell, the composition of the shell, or how the silicone is filled or created, like how cross-linked it is, like how form stable it is. Okay. So the newer devices, today's devices, They tend to be, at least the ones that we use mentor devices which have high cohesivity, which essentially just means the silicone is a little bit more form stable. So if you cut into it, it's a lot like a gummy bear. It's not exactly like a gummy bear, but the fill doesn't run. Older devices, the fill used to be a little bit more runny, right? And the problem is if the shell ever fractured and the silicone would run out of the silicone shell and into the tissues, you could have a really, really big problem. It would cause this chronic granulomatous inflammation reaction in the tissues, and it's very hard to get rid of. As a matter of fact, trying to remove that when that happens, when it gets outside the shell into the tissues, the only way to really get it out is if you widely excise the tissue. It's very hard to see leaked silicone into tissues if it gets out of the periprosthetic capsule. That's a whole nother discussion. But so because of this problem, they studied implant rupture rates of these older generation devices, and they found that the implant rupture rate was about 1% every year. So at 10 years, about 10% of these devices were maybe rupturing. And so there was a recommendation, this is something I got to look into, but there was a recommendation that said, well, at 10 years, all implants should be replaced for this issue, right? Because if they're starting to leak, we want to get ahead of it before it leaks out into the tissues and causes this really big problem, okay? So to answer this question, older devices, it was a recommendation to switch out implants every 10 years. Newer devices, particularly ones that we use in our practice, which are more form stable, they tend to not leak, probably do not need to be replaced, okay? They likely could stay in there for a very long time. I know there are still, even so, and this is a question I need to, I've asked the reps, particularly the mentor reps, there is a recommendation by the FDA that after implantation at 5 years, you should be getting MRIs of your silicone devices to look for these silent leaks before they start leaking out into the tissue. And then 3 years after, every 3 years after that. But with these form stable devices, do we really need to be doing that? I think the answer is no. And maybe Dr. Montziaris.
But as of 2019, the FDA says that high definition ultrasound is equivalent to MRI. So I think part of the problem with the old school recommendation was that for those of us who've had a breast MRI, it is severely uncomfortable, and that insurance didn't really want to pay for a bunch of expensive breast MRIs just to look at women's breast implants. So the patients didn't really want to have an MRI because it's uncomfortable and they might have to pay a ton of money. The insurance didn't want to pay for it because that's what insurance does. But, we're fortunate ultrasound technology has come a long way. Now people have handheld ultrasounds in the office and can look at these implants themselves. In my practice, I adhere to the 2019 FDA recommendations. If a woman's got silicone implants, I agree with Dr. Jablonka completely. All the implants I use have that gummy bear fill. I'm not using those old nightmare implants that were filled with like toothpaste gel and the silicone was going everywhere. But regardless, at 5 years, I'll send my patients for an ultrasound, and then every couple of years thereafter. And if something happens in between, they're like, Doctor, a horse kicked me. I got in a car accident. Something hurts or feels weird. Then I'll send them in between. A breast ultrasound is quick and easy. They get the answer from the radiologist while they're sitting right there. It's a fairly cheap study. The insurance isn't giving us all the same rigmarole that they do with MRIs, and it gives the patients peace of mind because we really don't know with these newer generation implants when they need to be swapped out. So I tell my patients, if you're 30 or 40 years old, this thing it's man-made. It may not last your whole life, but we don't just have to go in at 10 years, just like you have to go get your oil changed at 5,000 miles. I tell women it's more like the tires on your car. If you drive far enough, you may need a new set of tires. The tread may wear out. If you live long enough, you may need your implants swapped out or not.
Thank you so much. Thank you. So I did want to, because I said we were going to answer 2 questions. So I'm going to ask one more, and then then I promise we could just stay here all night, but then, that we can't. So I would like to ask Dr. Javinsky, if he is still on with us, if you can maybe respond to this last question. What are the recommendations on the best way? And this is such a great question, to monitor metabolic health after a breast cancer diagnosis. Dr. Javinsky, any thoughts on that?
Yeah, well, it depends on what you mean by metabolic health. I think you focus on eating well, maintaining a good diet, maintaining a balanced diet, avoiding toxins, and exercising regularly and going for your routine checkups. I did want to mention one thing about the implants, and that wasn't mentioned, and that is silicone implants rarely, but have been associated with diffuse large B-cell lymphomas as well. And while that's very uncommon, it is a complication of long-standing silicone breast implants. And so we ought to be aware of that as well.
Well, sadly, we have come to the end of our evening. I mean, literally, we could stay here, but you have very important work to do, all of you. I cannot thank you enough. Truly, I have learned so much. I'm going to listen to the recording over and over again. Thank you to all of our panelists. Thank you to all of our participants. I'm already have so many thoughts about next year and how to expand this further so we can provide more information. So again, to everyone who attended this evening, especially our experts, thank you so much for your time, your compassion, and for all that you do for those facing a cancer diagnosis. I hope everyone has a great evening, and the remaining questions we will make sure that we send out so that way we can try to obtain some answers for our participants. Thank you again, everyone.
Thank you.
Good evening. Thank you.
Okay, bye-bye.
Bye.